Very much. I'm Makaitaishe Basikoro, and good day to you all. Zimbabwe has a TB incidence rate of around 204 per 100,000 people, and over 500,000 people work in artisanal and small-scale mining across the country. The informal nature of artisanal and small-scale mining means miners operate with little regulatory oversight, exposing them to poor health and safety conditions. Miners face exposure to silica dust, which causes silicosis, a progressive irreversible lung disease. Individuals with silicosis are 2.8 to 39 times more likely to develop active TB than the general population. Tuberculosis preventive therapy, TPT, is a critical intervention that prevents latent TB from progressing to active disease, and the World Health Organization recommends it for high-risk groups, including people with silicosis. Between 2022 and 2024, silicosis diagnosis increased sharply from 64 to 350 cases. Over the same period, TPT initiation dropped drastically from 82.8% to just 12.3%. This widening gap between diagnosis and preventive treatment represents a critical missed opportunity, as silicosis combined with TB significantly increases the risk of mortality. The study aimed to determine the barriers and facilitators to TPT initiation among individuals with silicosis in Kwekwe, Zimbabwe. We conducted a 1:1 unmatched case control study, and participants were selected from hospital records using simple random sampling with the random number generator in Excel, resulting in 118 cases and 118 controls. Data were collected using an interviewer-administered questionnaire, a key informant's interview guide, and a checklist. Bivariate and multivariable analysis was performed using FIN2026 7.2.6. Cases were defined as silicosis patients diagnosed through chest X-ray between 2022 and 2024 who were not initiated on TPT, and controls were silicosis patients diagnosed through chest X-ray in the same period who were successfully initiated on TPT. Demographics characteristics were similar between cases and controls. Both groups were predominantly male, with a median age of 38 years and an interquartile range of 32 to 46. The majority, 61%, had attained only primary level education. Both cases and controls showed high awareness of silicosis causes. However, significant knowledge gaps were found among cases. Only 41.5% of cases knew what TPT was, compared to 82.2% of controls. And only 19.5% of cases believed TPT was effective, compared to 80.5% of controls. Cases also had lower awareness that silicosis increases TB risk. Income loss from clinic visits was nearly universal in both groups. A higher proportion of controls reported high TB risk perception compared to cases, and alcohol use was slightly higher among cases, and stigma perception was more prevalent among cases than controls. Cases reported higher rates of non-integration of TB and occupational health services and non-availability of TPT. A greater proportion of cases also lived 10 kilometers or more from a health facility and accessed occupational health clinics. Nearly all participants had 10 or more years of mining experience, with similar proportions across cases and controls. Personal protective equipment non-use was also similar between the groups, and daily dust exposure was slightly higher among controls than cases. After adjusting for confounders, Income loss from clinic visits was the strongest barrier to TPT initiation. Stigma perception also increased the odds of non-initiation. Conversely, good TPT knowledge and high perceived TB risk were significant facilitators, making minors more likely to initiate TPT. Participants consistently described loss of income associated with clinic visits as a key barrier, particularly for informal minors who depend on daily earnings. This opportunity cost often outweighs the perceived benefit of preventive care. Families at home may not support clinic visits unless the minor is already visibly ill. Stigma emerged as a further layer of complexity. The association of TB with HIV, chronic illness, and death led some minors to avoid engaging with TB-related services to protect themselves from social judgment. Fear of being seen as sick discouraged individuals from initiating TPT even when it was available. Despite these challenges, the study identified several facilitators of TPT initiation. Participants with better knowledge of TPT and those who perceived themselves to be at high risk of TB were significantly more likely to initiate therapy. This suggests that when barriers are addressed, demand for TPT can be activated. Self-reported data on alcohol use, perceived TB risk, and stigma may be affected by social desirability bias, potentially leading to underreporting of alcohol use and overreporting of perceived TB risk. Recall bias was also a concern since some participants were diagnosed as far back as 2022. Additionally, variables like perceived TB risk and TPT knowledge were measured cross-sectionally and may not reflect participants' attitude at the time of diagnosis. The study established that individual-level factors such as poor knowledge of TPT were significantly associated with non-initiation of TPT. Systemic and structural challenges, including stigma and the economic burden of clinic visits, emerged as key deterrents. Despite these barriers, the study also identified important facilitators, including patients' willingness to take TPT when well-informed and high perceived TB risk, which point to actionable opportunity for program improvement. In the short term, we recommended launching awareness campaigns for minors and their communities to emphasize the connection between silicosis and TB and to highlight the importance of TPT in prevention and sensitization programs and to reducing stigma and misinformation. In the medium term, we recommended providing TPT to mining communities through mobile clinics and outreach programs. Additionally, the use of digital tools and peer support can help ensure that miners complete their TPT. For the long term, we proposed establishing occupational health units within mining areas and connecting them with TB clinics to provide comprehensive care. As part of the public health actions, over 200 artisanal and small-scale miners were educated on TB, silicosis, and TPT. And we also, two artisanal miners association leaders were engaged and committed to championing safe mining practices and facilitating health screening access for their members. Would like to acknowledge the Provincial Medical Director of Midlands, District Medical Office of Kwekwe, Health Studies Office, my Field Supervisor, Dr. Kavenga, my Academic Supervisor, Professor Chirenda. Here are some of our references. Thank you.